So earlier this year, a group out of Germany published an observational, long-term observational study over about 14 months of patients age 16 to 55. There were about 140, 139 patients that were enrolled, and they actually analyzed 124 of those. They again looked at these patients at 6 months to 14 months over the course, so at 6, 12, and 14 months as they were treating it. And this was looking this was observational. So the patients received their medication through their insurance the standard way. This was a clinical trial. This was an analysis just looking to see if there was improvement with the Nusinersen. And over that time, what they saw, and these again were people between the ages of 16 years and 55 years, and they saw at 6 months in the Hammersmith scale, there was about a 28% improvement. At 10 months, there was 35% of the patients showed that clinically meaningful improvement, and at 14 months, about 40% of them. Now, it's important to remember those numbers show improvement. The percentage that shows improvement, as you go further out in a clinical trial, the number of people that continue in the clinical trial gets smaller and smaller. So you get some tricks in terms of the statistics. But the bottom line on this is you've got a disease, spinal muscular atrophy, that is gradually progressive. We know this from the natural history. And as we get older, it's going to decline more and more, gradually progressive. And now we've got a treatment that in this observational study, you had a high percentage of patients that either stabilized or showed some modest improvement. That is a huge benefit. It may have not cured their disease, but it prevented the decline. That's the take home from that study. The dosing was the FDA approved dosing. So they had the standard loading dose, and then they went to the standard maintenance dosing afterwards. What I didn't comment on is they looked at several parameters. The Hammersmith was the primary. The 6-minute walk test for those that were ambulatory was one of the secondary endpoints, as was that right upper limb module we mentioned before. And they looked at cough, and all of those showed that same results, that there was some partial improvement in that. But this was all using standard real-world dosing that would be through the FDA approval. The most important part and the key factor in this is that this disease is known to have a gradually progressive course, and this validated what we have been seeing clinically. When we treat patients with Nusinersen, we get the reports from the patients that they're stabilizing, but we don't really have the data that backs that up. There have been a couple of scattered reports of single sites, what they have been seeing, and most of them have been reporting stabilization with this, but they'll do it on 10, 20, maybe 30 patients. But when you start getting over 100, you start getting more and more patients that now the data becomes valid, because there, when it's a small, there could be errors, there could be site problems in terms of well, it's just you have problems with small sample size. By going to the larger numbers, you get rid of a lot of those errors. And the strength in this is the sample size, number one, but number two, that there wasn't a decline. There was at least stabilization in treatment of SMA.
The pivotal trials, only infants and children were treated with Nusinersen, but the approval also includes adult patients. Before we had performed that real-world evidence trial within the adult patients, there was that lack of data, and that was the reason that Nusinersen wasn't reimbursed in every country worldwide. So we decided to perform that trial to test the drug within the adult population, and we found that it is also efficacious and is also safe, like we found in the CHERISH and the INDIA trials. And this primary outcome parameter we choose the same like in the CHERISH trial, the Hammersmith score, and on the secondary outcome parameters, we choose the revised upper limb module, and for the patients who are ambulatory, the 6-minute walk test. And in every case, we found a significant improvement of motor function, and especially in the SMA type 3 patient, we also find with increasing treatment time an increasing number of patients that reach a clinically meaningful improvement of the motor function. But this does not exclude that SMN2 type patients don't have the same amount of motor function increase, but they stabilize. And this is also an important treatment goal in the very severely affected patients. The study is important because it completes the data we also have on infants and children. And the important message is that patients cannot be too old to get on treatment, because we don't find a correlation with patient age. And some of our best improvers in the study were patients which were above their 50s. So it is important that treatment is initiated as early as possible to get the best effects on motor function. But on the other hand, patients cannot be too old for getting on treatment.